Thanks, everybody, for coming out. I'm going to lecture to you on female stress urinary incontinence. It says 2023. I really need to update that slide, 2024. So what we're going to try to do here is go over stress urinary incontinence in women, talk a little bit about terminology. I'm going to talk about the three procedures that I'm doing most commonly in my practice now: bulking agent, midurethral sling, and ACT, and then understand how I maybe pick one over another, and if we have time to look at some head-to-heads. So when I see a patient with incontinence, I want to know how long it's been going on, what are the triggers, is this interfering with activity, lifestyle, how many pads you're using, have you had prior surgical therapy, what risk factors you have going into the surgery, what I sometimes call adverse implantation features, and then I'll direct appropriate therapy. If you ask the AUA what is the basic evaluation, and this comes up, I just saw this question on my recertification exam. History, physical, UA, and PVR are the four things you need to do before you operate. You notice you don't see urodynamics there, you don't see cystoscopy. This is on the index patient, and I'll define who the index patient is. Based on panel discussion, for the more complicated patient, you can do urodynamics and cystoscopy, but it's not needed in everyone. I tend to do it in everyone. I think that it's just how my practice is, and I'm set up certainly to do that, and I never regret doing more evaluation rather than less. So who is the index patient? The index patient is someone who hasn't had prior surgery. They have hypermobility. So when you hear me talk about the index patient in this talk, that's who I'm speaking to. The hypermobile ISD patient is very similar. They just have a lower leak point. So kind of put those first two bullets together. The pure ISD patient is someone who doesn't have any hypermobility, and then the ISD cripple is usually a neurogenic, or they're the patients that we sent to Fiona. All right, so just as a show of hands, before we even answer this question, how many people treat women with incontinence? Okay, good. So we have a little bit of an audience. I know urologists kind of are moving away from that, and I find that upsetting. All we get is that ISD cripple, right? We don't get necessarily the index case. So of your procedure of choice, for those that raised your hands who are actually doing this work, how many people would offer a bulking agent to the index patient? 58 years old, how many people would do bulking agent? Okay. How many people would choose a mini sling or a TOT? Retropubic sling? Okay. Autologous pubovaginal sling? Maybe. ACT? Okay. Okay, good. So I'm going to see, we'll go back to this slide later and see what the opinions are. And I easily could say 1, 2, and 3 are very reasonable. I think D&E would be more for that more severe patient. What about bulking agents? So how many people are bulking these days? Okay. How many people are doing more bulking than they've ever done in their practice? Yeah. So I think when we came out of sort of the mesh controversy, bulking got very popular, and we have some new agents. And so let me just speak to bulking and what your expectation should be for that patient. It's office-based. So you heard this with the BPH talk, right? Everyone wants to have an office-based procedure and maybe a surgical procedure for that disease. We want low complications. This certainly has low complications. Local anesthetic, and really no recovery. Does anybody restrict their patients after an injection? No, I mean, I've had people literally go back to work the same day. So this is the least invasive. Disadvantage would be a lower cure rate, okay? And I put cured and improved together, but I'll show you about a third of them are cured versus 2/3 improved. And so that's a number you have to really break down when consulting patients. The need for re-injection, and then what's the long-term safety. So transurethral bulking is not new. I've been bulking for 25 years. We kind of wax and wane in our interest based on kind of what's going on around us. But this is done transurethral, okay, through your cystoscope. I'll show you later with ACT, a paraurethral procedure. And bulking can be done paraurethral, but most people do transurethral. So the logistics of this is I tend to offer it to people who aren't really great candidates for anything else. They tend to be older. They have a very low risk tolerance. Maybe they have comorbid conditions. But I would submit, and I saw by the raise of hands, some people are offering it as a first-line therapy, even for younger patients who maybe might need multiple injections in their lifetime. The continence does decline over time. If you look at the studies, the longer they follow people, the more people move from cured into that improved category. There's a lot of enthusiasm for the new agents, but we've been through this before with other agents, and will they prove to be durable? So the Bulkamid, I think by far is the most common. Is anybody using anything other than Bulkamid to bulk? Yeah, I mean, this was like overnight, they got 100% of the market. I used Macroplastique. Before that, I just did Contagen. So those are my 3 agents. And at some point, you need to move on. And I think what they've done well is standardizing the procedure and really teaching it well. So as I mentioned, 67% of people cured/improved, 11% no improvement, and then 2.3% worse. So occasionally, you'll see a person that gets worse. To me, that's unusual. It probably means you injected too deep into the sphincter, and this certainly happens in the male patients, so I'd voice some caution on that. It's not FDA approved for men. There's a systematic review now, 8 studies that is pretty good data I'm going to go through with you next, but about 24% of people need a re-injection. So this is the basic setup. You're going to typically do 2 syringes, which you'll do 4 injections. And the majority of patients are going to be improved, not cured. So you're going to have 16% cured, and you're going to see 50% improved. So when they put that cure-improved number together, most of those are improved, not cured. And then if you look at the number of injections during the study period, about 32% of people are going to get re-injected. So I think these are good numbers to share. If you're going to go down the road with this patient, these are the expectations that you should be giving them. How do we do it? I think, again, they've standardized the procedure well. They'll come in your office. They'll train you on a pig urethra, pig bladder. Generally, most people do 2 syringes, 4 injections. You're going to be about 2 centimeters to 1 centimeter from the bladder neck. And it's like any other injectable and trying to get that coaptation right from the beginning. I don't do a cough test because I'm going to inject 2 syringes and I'm not going to inject a 3rd. So I'm not really interested to see what the cough test shows. Don't overfill the bladder when you do this, about 200 milliliters in the bladder when you're doing the injection. So bulking agents are viable. I think the AUA is supportive of this. There's little long-term data. For some patients, this is the right option. For other patients, I'll argue that there may be better options. So what about TVT and TOT? This is a fun slide that I've shown for many years. And if you look at where we're at now, we're kind of over the mesh controversy, and now we're back to doing mesh again. And there was a period of time where people went to autologous and allografts. When we went around the circle the second time, we skipped the biologics. On this time, people really didn't go back to biologics. They went from autologous back to mesh. The TVT device has been used since 1996. Ulf Olmstein is the inventor. And why this got so wildly popular is it was just as effective in what he called ordinary urogynecology units as it was at the academic centers and tertiary centers. And so this was a procedure that traveled. Why did it travel? Safe, fast, easy, reproducible, right? So that's what you need when you need a procedure for the masses, right? Over 200,000 operations being done each year for female stress incontinence compared to about 5,000 for men. So you need an operation to really treat such a big demand. And unlike the bulking, you can see most of them are cured, right? If you put the cured and improved together, the number goes from 67 to 90 when you compare to bulk, and most of them are in the cured category. So this is a very robust procedure, studied long-term, 17-year data now on the device, 90% cure rates. How do I do it? I like a full-length retropubic tape. I think that's the gold standard. And I can share with you guys later my technique. I won't get into too much detail, but you certainly need to do a cystoscopy at the end of the procedure with a flexible or rigid and make sure that you're seeing all of those areas. I like to break through the retropubic space with scissors, and then I break down any adhesions. Most of mine are redos, and I find I have a lower incidence of bladder perforation with that technique. So the advantage of this, proven durability, long-term durability, shorter OR time maybe compared to an autologous sling, shorter convalescence compared to autologous data, ideal for the index patient, especially if they're younger, but there's still some lingering concerns about graft complications, and I think for some, maybe they don't do a lot of incontinence work, and they want to just, keep it simple with bulking, and maybe they refer these cases. I didn't see any hands really go up for TOT. Is anybody doing TOT? Okay. And is it for this reason, Matt? You like TOT?
That's what I was trained on.
What you're trained on. Yeah, and I think a lot of us are trained on TOT. We like avoiding bladder injuries. This was always more popular in urogynecology. And the success rate is nearly identical to TVT, as long as it's not that ISD cripple patient. If it's the ISD cripple patient, you're going to have 4 times more likelihood of failure in TOT versus retropubic. Long-term data is very good on TOT. And let's get into the evidence, right? I think some people think the highest level of evidence is a randomized control trial. Actually, it's a systematic review. So systematic reviews have been done on these devices. If you look at the Cochrane review and those collaborations, I use them a lot in my practice. I find them very useful, very powerful. So this is one from 2010, 7,000 patients studied on the device. Follow-up Cochrane review, 12,000 patients, 2015. Mid-urethral sling operations have been the most extensively researched surgical treatment for SUI in women, good safety profile. So I think you could feel well supported by this data and feel comfortable if this is something that you offer. You should be using a type 1 mesh. Okay, what is type 1? Macroporous monofilament. Okay, those are the devices you should be using, lightweight, not heavyweight. You want it to bend. Bending is good. You want some displacement underneath the urethra when people are active, but not to break. So what does the AUA say, and do they support this? Yes, the AUA put together a policy and said the suburethral sling is the most common surgery for SUI, a ton of data to support this. When compared to autologous tissue, less operative time, less convalescence, really less complications, less anesthetic needs. And so a full-length sling, okay, full length, remember that word, not mini, full length, either retropubic or obturator, is the gold standard for female stress urinary incontinence. And the other societies support the device through the whole controversy. I think that's how we got through it. It's important to be active in your subspecialty societies because this is where they could really make a difference in putting together position statements that you can use in your practice. And the societies continue to support the device. What about the autologous sling? I use the autologous sling, but that was always my salvage procedure. I chose it as a salvage procedure because I got to make an abdominal incision. It's more time consuming, and there's morbidity at the harvest site. So what about future directions? Just trying to maybe bring something new or bring some awareness about some other things that are going on. People say, what about stem cells? When will we have stem cells? I was involved in a trial with Cook Myocyte, looking at muscle cells, so myocyte. This is not a stem cell, it's a little further down the line. Melissa Kaufman is the lead investigator on this. And I haven't done enough of these to really feel comfortable sharing data with it, but I think Melissa and others are, and this continues to go forward. But these studies take a very long time. This will be done just like Bulkamid, but it's done transurethral, entirely organic, nothing synthetic involved. ACT, I'm the lead investigator in the US on ACT. We're now up to 5 sites in the US and 3 in Europe. And so ACT is very similar to the PROACT, right? Pro for prostate, ACT, adjustable continence therapy. So the same therapy can be done in women. Think about this as bulking, and you can continue to bulk and add volume to the balloon, so it gives you a little bit of options, 2nd, 3rd, 4th options without having to do a re-injection. The balloons sit on either side of the urethra, para-urethral, not peri. Peri is around the urethra, right? Para, right next to urethra, 3 and 9 o'clock position. You can see the balloons sitting there right at the bladder neck. above the urogenital diaphragm. This is an example on an MRI image of the balloons filled with contrast. And then here's some pictures of the procedure. So think of this like a TVT, but you're not going transvaginal. You're going translabial, okay? And you're going to tunnel the trocar into place. And you can see the incision here right at the level of the urethral meatus, right between the labia minora, labia majora. And then the tunneler goes in and gets tunneled to the bladder neck. The balloon gets pushed through the U-channel sheath. Think of it like Seldinger technique. And then the balloon gets adjusted at that moment. I tend to put 0.6 in the balloon, and then I'll add a milliliter each month, up to about 2.6 is generally going to be our target to get them dry. So what does the data show? ACT is not new. ACT has been in Europe. Okay, to get any device approved in the US, you need at least 5 studies, 2 of which are in the US. And so this is the French data from 2000 to 2018. Okay, so this is some data that's pretty mature, people being followed all for at least 1 year. 37% were success, meaning that they were dry. 33% improved, so you can put the numbers together, right? And you could hit around 70%, and then 30% failed. Almost everybody had a prior sling, okay, and as much as 18% of this group had radiation. So this is a very challenging reoperative population, similar to maybe where you'd be using your autologous sling. Next study in the US, 162 patients, 76% of people were improved. Remember, cured/improved are being lumped together. And then 18% had to get explanted. So there was some work to do, but realize this is the initial series pilot study in the US. Okay, so the pad weights, generally on a provocative test, went from 50 grams down to 11. Okay, so about 80% improvement. And then the complications look similar to tapes. Erosion, infection, migration, mechanical failure, no different than any other medical device. Second study in the US by the same group, now with 3-year data showing 92% cured/improved, 47% of which were dry, reduction in the STAMI scales, and improvement in your quality of life, and decrease in your urinary distress inventory score. Went from about 4.3 pads to 1.9, 21% got explanted. So pretty similar to the European data. And again, the pad weights are going 77 grams down to 25. And most of these patients were treated previously with bulking or with a tape. This is the last study I'll share with you on ACT. And you can see over time the continence got better. So you went from 5 pads to 1.6 to 1.2 to 1 to 0.41 at 72 months. So instead of the results getting worse over time, they're getting better because you can do just additional adjustments, which is really nice to have an adjustable device and not have to reoperate. Let's think back now. We talked about that index patient. So now we're gone beyond the index, 78-year-old patient, prior TOT, 10 years. This worked for 5 years. And that's important to know. And when I see a patient with a failed sling, my first question is, did the sling make you better, worse, or about the same? That is my favorite question. If they got better, then it worked for them. That was probably the right diagnosis. Maybe it was a tensioning issue, or maybe over time they developed worsening ISD. So I really want to focus on that. If they got worse, it was too tight and they're obstructed, usually retention or de novo OAB. How many people with this patient failed sling 5 years ago, 4 to 6 pads, pretty high volume? How many people would bulk? Come on, be honest. All right, there's one. Repeat TOT? Matt? No, that's not the answer, okay. Retropubic TVT? Nice, yeah, and that's what most people answer. Autologous sling? Okay, yep, and that's what I was doing for the last 20 years. And then the last 2 years, ACT. So if people have patients that are really severe, they want to try something different, I'd be very happy to talk to you. I'm sure we all have a couple ISD cripples that we're hanging on to that we'd be happy to share. And you don't have to send them to Switzerland. Okay. How about F? Who would go with F? Fiona, F? Would you do F? Okay, no, thank you. Because she showed with the bladder neck closure, people think of that being as the final operation. That's going to fail probably a third of the time. They're going to refistulise. Now you're going to be using a bowel segment, Mitrofanoff. I got to believe there's a couple other options before we'd get to bladder neck closure. All right, finishing up here on head-to-heads. If you look at TVT versus bulking, you have a much higher percentage of people that are satisfied. Why are they satisfied? More of them are cured. More of them didn't have that repeat procedure. So if you look at the cure rates, they're higher, both objectively and subjectively. Decrease in pad weight, performing better on the retropubic. But there's a reason why people like bulking, right? And why patients like it. If you look at the complication profile, there's almost zero complications with bulking, with the exception of a UTI. That's it. And I think some patients, some doctors are risk adverse. And I think if this is not a big part of your practice, you're going to say, yeah, the TVT looks great, but I just don't do a lot of them. Haven't done one in a couple of years, and I'm just more comfortable bulking. And I think that's fine as long as you counsel your patients about the cured/improved and the need for re-injection and knowing when to move on. So procedure selection, I put all of these things sort of into my head. I don't have a calculator, but I look at the medical factors, the social factors, and the urethral factors. And once I look at all these factors, it helps me decide. So if they have an adverse urethra, okay, they've had infection, diverticulum, I probably want something more organic for that patient. Social factors, there's patients that don't do well with implants. You look at that allergy list, it's long. Look at that, pay attention to that. Okay, that might be someone who's going to do better with an organic repair. Patient factors, surgeon factors, they influence you a lot. What your training is. You know, Matt mentioned earlier his training was TOT. That's what he does. It's very hard to teach yourself how to do new procedures once you're in practice, unless you have supportive partners. You know, the idea of these weekend courses to learn things, it can be done, I think, for some patients, but you at least have to have, for some surgeons, some basic knowledge. So to learn how to do a TVT, maybe after doing a mini sling, that's a very small difference. And so I think you tend to move towards procedures that are maybe similar to what you were doing. So this is where I picture the incontinence practice that I have. You know, 80-90% are going to be in those first three boxes. And then maybe 5% goes to the fourth box, ACT. And then very rarely do we need to divert someone. I feel personally it's almost a failure if I have to divert someone for incontinence, whether they're neurogenic, non-neurogenic, radiated, non-radiated. I feel that there's still a solution there. And people look at cystectomy and diversion as being the terminal procedure for incontinence, but even then you could revise ureters, revise stomas. So just to finish, bulking agents are gaining significant popularity. Professional societies support that. They also support the mid-urethral sling. 17-year data on mid-urethral sling, a number of head-to-head trials that I showed you are going to support that in your practice. And then the last thing would be to consider AACT. If you're interested, I'm happy to talk to you about that. There's up to 8 centers that we have going now for ACT. And this is a group of my fellows. This is one of my favorite slides. I always throw this in the talk. Nate Coddington asked me the other day what number fellow he was, and I was off by 1, and he was number 16. I couldn't have done it without the support from these 17 now individuals. Thank you.